Welcome to the PsychopharmaStahlogy Show, a special NEI podcast series. In this show, Dr. Andrew Cutler interviews Dr. Stephen Stahl on the most controversial, novel, and exciting topics in psychopharmacology today.
Hello and welcome to another NEI Podcast. This is another in the series of PsychopharmaStahlogy shows with the one, the only Dr. Stephen Stahl. And Steve, I'm imagining this one is going to be near and dear to your heart because we're going to be talking about MAOIs.
Very good, yes. I'm excited about doing this one.
You've been talking about these for some time now, and especially saying that as psychiatrists and as mental health professionals, we need to have some tools and some tricks of the trade here for when people get referred to us and have tried the usual stuff, and this is certainly one of them. So this is another in our series of underutilized psychiatric drugs. We've talked about clozapine and lithium, and today we have with us a real friend and colleague, and actually my boss at SUNY Upstate Medical University, Dr. Tom Schwartz. How are you, Tom?
Hey, not too bad. Great topic.
I think so, too. I really do. We got so enamored of reuptake inhibitors that I think people have forgotten that there's more than one way to raise monoamines. And so why do you think people are not being trained or are using these medicines enough?
From my end, I guess I have two answers, and one hurts. One is we're lazy. Right? Mm-hmm. We don't use them. You have to retrain yourself. You have to look up dosing and diet and drug interactions. And in our busy lives of seeing a patient every, 15 minutes, 20 minutes, it takes a lot of effort to stay sharp and then look up a drug you haven't used in 5 or 6 years. So I got to say, we're probably lazy in some ways.
Yeah.
And that's, I think trying to be a little controversial. But the other one is these are riskier meds, right? We can hurt people with these. And so we save them for later and later. And as we get newer, safer drugs, we save the riskier ones for later.
Steve, it occurs to me that there's some similarities here between clozapine, lithium, and this one. You have to kind of know how to use the drug. There's some more risk. It's a little harder to use these drugs, and yet they're so damn effective.
Yes, it does take some skill. It does take some experience, and there's a sad lack of mentoring about how to do that. And I think one of the ways to do this is to get your feet wet and get some experience with it. You're not very good at things you don't do often, and so the idea is that all you have to do is have one patient who has gone through hell and back with their treatment and then be transformed with improvement, and it'll make you a believer. Doesn't happen all the time, but it happens enough that this should be in our toolbox.
Yeah, I certainly agree. And I know there's risk, and people get scared, Tom, of the hypertensive crisis, the tyramine situation, but I'm reminded of a phrase a friend Terry Ketter used to say, which is, we worry about side effects of drugs when we think about risk, but what's the risk of inappropriately treated illness? What's the risk of not adequately treating depression?
Yeah. I think on one level, under-treating or not aggressively treating breeds treatment resistance, right?
Yeah.
We don't really get people to remission. A year goes by, 2 years, 3 years. I think it's really hard to treat people. So I think you're absolutely correct, and then certainly suicide risk and things like that add up as well.
Steve, the atypical antipsychotics are certainly very effective, but I'm really worried about weight, metabolics, and especially tardive dyskinesia. Where do you think MAOIs should fit in the algorithm? Should they be in there with atypicals?
Well, that certainly is the time when you could use them. Realistically, probably people are going to use them just before or just after ECT, I would imagine.
Mm-hmm.
But it's like anything else. Once you get some experience with it, you'll move it up from last, to further, closer to the front. So there's forms of depression which are particularly well groomed for that, and one of the worst ones I think is this new thing, anxious distress, put with depression, and one of the drugs, phenelzine, is particularly good for that. And then, of course, some of the more melancholic and apathetic depressions would be maybe for the other one, tranylcypromine. And so do you have to wait? I mean, how long? How many psychiatrists do you have to go through? How many, treatments do you have to go through? Because by the time you see somebody on an MA inhibitor, I would say they're almost always been sick for 2 years or more.
Yeah.
And so that's 2 years of lost time. And then, all right, smart Alec, what are you going to do now? When they've had 2 years, I mean, probably you've used all those atypicals you mentioned. Maybe you've even had ECT. And so now what are you going to do? And the worry is that you say, well, we'll do the best we can. Well, you get a partial response and whatever you're on, let's just keep that on forever. Because I'm treating myself. I feel more comfortable not using an MAO inhibitor. So that's not a good answer.
Yeah. Well, Tom, how do efficacy rates of MAOIs compare? What are some of the data that suggest they are very effective?
Yeah, I kind of like Dr. Stahl's comment. I like to say all antidepressants are kind of FDA approved the same way, jump through the same hoops, do similar clinical trials, and our antidepressants get an average number of patients average better. So on one level, I think they're about the same, though I do think there are kind of niche or special populations, and where I see it, people that used to have something called depressive personality. And with depressive personality, to me, it's a dependency, avoidance. You have these personality traits, right? Maybe atypical depression flavored that way. And, I think the MAOIs have a really good niche there. I couldn't tell you there's a 300-patient subject study to prove it. But I think we have kind of anecdotal, smaller studies that may be avoidant personality, chronically socially anxious, avoidant, and depressed. I kind of think
Tom, let me ask you this. How come maybe these people have a depressive personality because they've been sick for 4 or 5 years?
Yeah.
And and it's not really a depressive personality that existed pre-morbidly, but they've been sick so long that they get a negative view of themselves, of the world, and of the future, the classical Beck triad. And why wouldn't they? They haven't gotten better.
Yeah. Well, learned helplessness. Yeah, and I think that is what happens. Absolutely. Yeah.
Now, Steve, you mentioned for a couple different subtypes, and I think you were talking about sort of the melancholic depression there when you were talking about tranylcypromine. I was also taught that atypical depression can respond to MAOIs. Mechanistically, what are they doing that might be a little different? Tom, what are they doing mechanistically that's different from an SSRI or SNRI that maybe helps us understand this?
Yeah, I mean, I remember one way being taught, how we memorize, SSRIs, SNRIs, NDRIs, SPARIs, SARIs, NASA agents, all the good antidepressants. We memorize all these unique mechanisms. But when you don't want to worry about anything, you use an MAOI. Because all 3 monoamines go up, right? Serotonin, but you're covering everything, like broad spectrum antibiotic. So, if you can't break down those transmitters, you're going to build up more and more of them. You hit all 3. So you're covering your bases. I remember being trained that way. It's one of the easier mechanisms to remember.
So SSRIs are really just blocking reuptake of serotonin. SNRIs are serotonin norepinephrine, but the MAOIs are preventing the enzymatic breakdown of all 3 of the major monoamines, including dopamine.
Oh, wait, breaking news here. There's and that is that you may not know this, but it's been recently discovered that phenelzine is actually broken down into a GABA transaminase inhibitor.
Whoa.
And so you get 4 for the price of 1. You get dopamine, norepinephrine, serotonin, and GABA. And this is postulated as being the reason why phenelzine is so effective, not only in anxious depression, but in fact for anxiety states like really bad panic or social anxiety. People don't realize, even without depression. And so it's pro-GABAergic. And in the case of phenylcyclopropylamine, which is also called Parnate or tranylcypromine.
Tranylcypromine, yeah.
It's basically amphetamine. If you ever look at the structure of it, It's a cyclized one bond differently on the aliphatic chain. If you want to get technical about it, it basically looks like amphetamine, and it acts like amphetamine, particularly as the dose goes up. Yeah. And so you can get a little bit of a zing and a boost and a zippity doo dah out of it. So one of the things that we'll get to perhaps is that one of the augmentations of these agents are stimulants, methylphenidate or amphetamine. Mm-hmm. Well, actually, tranylcypromine, if you raise the dose particularly, it is amphetamine.
Right. So you get a lot more dopamine kick.
Now that we're talking amphetamines, too, I ran into a situation with Selegiline, the patch, right? The patch MAOI, handful of years ago, at a somewhat elderly female patient come up positive on methamphetamine, urine screen. Because metabolites, right? So even Selegiline downstream
It was
converts
Selegiline.
into amphetamine-like metabolites, at least. So, I didn't want to accuse her of using crystal meth all of a sudden, so I had to do my homework and figure out the metabolites,
That's a really important point, Tom. People need to know that if you're going to use the Selegiline patch, it will convert the urine drugs here. Steve, the other thing is monoamine oxidase is not only extracellular, it's intracellular.
Well, yeah, it's in mitochondria. And so the outer membrane of mitochondria is a localization of it, and, it's in synaptic terminals.
Right, so you may even be kicking some more of the monoamines out, not just blocking them from being taken up. That's really, really interesting. All right. Now, certainly I was trained that MAOIs are the best treatment, and I believe, Steve, it was our friend David Sheehan who had published some of this for panic disorder. The MAOIs were the best treatment for panic disorder and social phobia.
Yes, I mean, if you... most people listening here may not have that experience of using them at all, and if they have, in their distant past, perhaps, maybe only for depression. But particularly refractory panic attacks are amenable to treatment with this, and also social anxiety, which is, of course, a form. I mean, here you have expected or unexpected panic attacks. The unexpected one you call panic disorder, and if you expect them going into a certain situation, you get them there, except you avoid it.
Yes.
And so you can have a really good outcome from that. And also this, we've talked about it, Andy and I have just lectured on this recently, the idea that there are forms of specifiers in the DSM this time around, and one of them is anxious distress or, modifiers of anxious depression. And that's a flavor of depression that the SSRIs treat about half as well as they treat the non-anxious depressions. And so, that's already a heads up. Now, it is true that many of the atypical antipsychotics, at least in post-hoc analyses, do work as well for both. And so that might be the way you start. People are much more comfortable with those. But what do you do if they don't work? You're going to go rotate through 3 atypicals? Okay, now what are you going to do, smart aleck? And so the issue is... not parnate, not tranylcypromine, but maybe phenelzine for those people.
Right. See, Steve, that's really interesting, Steve. I had forgotten that there's these mechanistic differences, if you will, or structural differences between phenelzine and tranylcypromine, the two most commonly used ones in the old days. So this is really helpful to clinicians to realize that maybe the phenelzine would be for the more anxious and the tranylcypromine for those who need the zing, the kick. Very interesting. All right, Tom, let's confront the elephant in the living room. Tyramine crisis, dietary restrictions. What do people have to know about dietary restrictions with the MAO inhibitors?
So I think we'll start with the easy one, the Selegiline patch. No dietary requirement at the low dose, and then the FDA would like the diet followed at the middle to high doses. It's interesting. I recollected 3 or 4 main studies, and some of them didn't have a dietary requirement.
I actually did a couple of those studies, Tom. We did not have any dietary restrictions, even in the higher doses.
So I can appreciate maybe 1,000 people went through the regulatory process. Maybe 1,001 would have a tyramine crisis. But I think there's a sense of safety with the patch, at least, that maybe you're pretty safe. If you... I don't want to say skip the diet, you goof up. You go to a fancy restaurant, you get a fava bean in your soup by accident, right?
Yeah.
You're probably safer with the patch at all doses. With the oral MAOIs, it's when patients hear diet, they don't like it. And they're thinking low salt, low carb, low fat, and those diets are no fun. I think I borrowed from one of Dr. Stahl's lecture when we're like, how many of you like to eat spoiled meat, fish, and poultry? How many of you eat pickled herring every day or banana peel? So to me, it's a list of 10 to 12 things. Most of them are kind of strange that we really don't have a lot of. And I think when you joke with patients about it like this, they go, oh, it's not that bad. Deal breakers, I think, in the U.S. are smoked meats, aged cheeses, and tofu.
So and it used to be red wine, didn't it, Tom, too?
Yeah, for oral agents, more alcohol restrictions. Yeah,
for me, cheese and red wine would be pretty tough. Yeah.
So I think when you get to those certain patients, they kind of have those kind of diets, and it's a bigger change. But if you goof up, it can hurt you. Blood pressure goes up, stroke, heart attack. These are no fooling around drugs if you goof up. Yeah.
My understanding is, though, that we've gotten a little less stringent with the dietary restrictions. What can you say about that?
Yeah, I think, there's kind of a card I found, they print out. It's a dietary card, and literally I think it's 10, 12 things, right?
Yeah,
it's not 40, it's not 50. I hand the card out, and, patients go through it with them, and you think you can avoid these things. If you're not sure, can you ask the chef? If you're not sure, you have my cell phone, you can call me. I'll tell you if fava beans are on the list, right?
Yeah. How about side effects? And I understand that there are some differences in the side effects relevant to what Steve said earlier between phenelzine and tranylcypromate. I guess phenelzine with the GABAs may be a little more sedating, tranylcypromate a little more insomnia activating.
Yeah, I think that's true. And again, if we throw in the Selegiline patch, to me, it's activating as well. So, yeah.
Well, the nice thing about the patch is you can certainly take it off, and adjust how long it lasts and things like that. I guess with both of them, or with all of them, we're worried also about orthostatic hypotension.
Yeah. In my practice, I don't see it with patch really much at all. I do see it more with phenelzine. But they both do it. But in my practice, phenelzine's a bigger culprit for orthostasis,
How about weight gain or sexual dysfunction? Those are two that are deal breakers to some degree.
Again, I've seen it with both the oral agents, but much more phenelzine. Yeah.
And then sedation?
Still phenelzine, I think.
Yeah, more phenelzine.
So, again, and not to mix classes, to me, it's like phenelzine handles like a lower potency antipsychotic. It seems to be a little messier and more tired, groggy, sedating weight gain. And the tranylcypromate can have those issues, certainly, but I think I see them less often.
Yeah. Okay. All right. Now, the third thing, we talked about the dietary restrictions, the side effects. The third thing is drug-drug interactions. There are quite a few of those, too.
Yeah. I think that again, when patients get scared of this, because they're going to get a list of the things that you can mix and match, and you get serotonin toxicity or syndrome, and this can also kill you, right? That's what they hear. Stroke from the diet, serotonin syndrome, and these things will kill you. That's what they hear. That's what they read.
Yeah.
I think what's helped, just in general, is I have my patients, they have to agree to use one pharmacy. They can't go from Kinney's to Walgreens to the grocery store. You got to pick one pharmacy, use their computer. All your drugs are there. And your pharmacist will never let you leave with like class 4 drug-drug interaction, whatever they're called. They will never dispense it to you if some other doctor puts you on an interacting med. So I like the safety. The pharmacist is your friend, but you can't use multiple pharmacies because there's multiple computers that don't talk to each other.
Yeah. So
all prescriptions, one location, one computer. And even over-the-counter meds, right? If you want vitamin C, you got to go back and ask for counseling. That's fine. Robitussin DM, I don't want you on the DM part. The pharmacist will tell you no. So I have a rule.
Dexamethorphan's a moderate SRI.
Yeah. So I do think I rely on the pharmacist. They're my professional friend, colleague, and if we use their one computer, we check all prescriptions, all over-the-counter things, right? We're probably not going to hurt you. And I feel
what's the prescription antidepressant with dextromethorphan in it today? Oh,
that would be good. Yeah, that'd
There's
be
a combination of
bupropion.
dextromethorphan and bupropion.
Yeah.
But Steve, I understand, obviously reuptake inhibitors are real big no-nos, but I understand that some of the, nowadays we're kind of getting a little more relaxed on some of these drug-drug interactions too. So for instance, stimulants used to be an absolute no-no, but now, maybe at lower doses, not so much.
Yes, I think you're right. I mean, you put these in different categories. A serotonin reuptake inhibitor could kill you. Okay,
yeah, that's bad.
So you need to know. So it's all SSRIs and SNRIs, of course. It's only two of the tricyclics. Again, you have to remember it. It's imipramine and clomipramine have a good serotonin reuptake. The other ones are more noradrenergic and actually can be combined by experts. Two of the so-called antihistamines are actually serotonin reuptake inhibitors. It's chlorpheniramine and brompheniramine.
Older ones, yeah.
And some of the so-called analgesics, cough medicine like dextromethorphan, but dextropropoxyphene, nobody uses that much anymore. Levorphanol, pentazocine, meperidine, though, Demerol.
Demerol. People don't realize, Steve, you're right.
Methadone, is a reuptake pump, and even tramadol in a little bit.
Right.
So, you got to know if you're going to memorize a group of things, the ones I just told you is pretty much the comprehensive list of all the things that block serotonin reuptake. You might want to even throw in ziprasidone and lumateperone because you can generally combine atypicals with an MAO inhibitor too. It's just not those two. Why? Because they have some serotonin reuptake blocking properties. So stay away from that. But you're right. So decongestants. If you have a cold, you can't take any medicine, right? No. You probably ought to not take dextromethorphan for cough, and you should probably be careful about decongestants. But antihistamines, other than the ones I said, chlorpheniramine, it's pretty much the way to go.
Yeah. The more peripherally restricted, the less centrally active. The newer antihistamines basically are probably safer. Okay, so we have that to be aware of. But, despite all this, you're always trying to do a benefit-risk analysis. The benefits here potentially are really high. And, the three of us have been around long enough that we've actually used these drugs and seen the benefit in it. Sometimes, Steve, as you said, when you see it with your own eyes and you really see somebody really doing well with these things, it really makes you want to learn how to use them. Okay, we talked a little bit, Tom, about Selegiline and the Selegiline patch. What are some reasons you might want to use that? First of all, I guess we should talk about, Steve, the orals are non-selective. They're MAO-A and MAO-B. Selegiline was reported to be a little more MAO-B, I think, but as you push the dose, I think it gets less selective. Isn't that true, Tom?
Especially if you use it orally, you can use Selegiline orally.
That's right.
In reasonable doses. It gets to be expensive because the Parkinson doses are only 5 or 10 milligrams. You need 30 to 60. So that's all A plus B. And but at the low dose, there's no dietary restrictions, and it's somewhat B selective on the patch.
But the thinking is maybe that's slightly less effective, that it's helpful to have the B.
Yeah, that's the problem.
So as you push the dose, Yeah,
and I think
so Selegiline's FDA approved also in the oral form for Parkinson's, so people may not be aware of that.
Yeah.
I do think patch, the old patch brand name was MSAM, I remember.
Right.
But it's generic now.
I do think when you speak with folks that grew up with the MAOIs, so a generation a little older than me, and then got to use the patch, the clinical lore and anecdotal reports are the oral meds seem to be a bit more effective. I'm not aware of any head-to-heads, but if in my practice, if somebody fails the patch, I'll go to an oral for that reason, and that's bailed me out here and there.
Do you tend to start with the patch, Tom?
I do. I like the safety of the diet part of it, and it has more of an upper feel to it. It's an activating med. Now, again, where I don't like it is in the anxious distress patient. It's not a great fit. But in my world, if you get used to prescribing bupropion, you have kind of a type of patient you like to use bupropion with, right? I think MSAM handles like that in day-to-day side effects. So maybe not so great for your really anxious patients. The other negative with the patch, I gotta say, is people get this glue reaction.
Yeah.
And it's easily 1% to 2% over time. And they start getting a big hive or a welt everywhere they put the patch every day. And one of the number one reasons I have to stop it is actually for that.
Yeah.
And it's not headaches, it's not stomach aches, it's not excessive weight loss. It's they really get a glue allergic reaction.
Do you know what I found you can try? And this is true with, we have some other patches in psychiatry too. There's both diphenhydramine gel, but there's also a lidocaine gel that you can use and pre-treat, actually. It dries pretty quickly.
Yeah.
Well, and that's another option.
Yeah. The other trick is you take the patch off, alcohol swab, and then soap and water, and you got to try to get the glue off. Yeah.
Yeah. Well, that's good. I did the studies, as I mentioned, with the Selegiline. We even did an elderly study where we pushed the dose, and surprisingly, we actually measured orthostatic blood pressures. We didn't see a lot of it. It was really interesting how well tolerated it was, even in the elderly. So I know some people may be afraid of using these drugs in the elderly too, but, if you're careful, you can use them.
We didn't mention isocarboxazid, which is on the market, but it's not got so much use, and it hasn't been studied as widely, and the differentiation from these other two agents is not clear. And then meclobamide, which some people want to import from Canada or Mexico or Europe. The knock on that is it's MAO selective, but it doesn't work very well. And so it's probably not worth all the effort to import it. You're better off to put your effort into learning how to use again, there's only so much that you can do. You're all busy, but if you can learn how to use not just the patch. In other words, what are you going to do if you slap the patch on low dose? It's easy. If it works, you're golden. And no dietary problems. It's selective. But chances are you're going to find patients that it doesn't work in and they can't tolerate the skin stuff. So now what are you going to do? You better know how to use a little bit of phenelzine and tranylcypromine. That's what might be my recommendation.
So, Steve, the ones we've been talking about are irreversible. Isn't meclobamide reversible, or am I confusing that with another one?
It's a REMA.
It's a REMA. I thought so.
Inhibitor of MAOA.
Yeah.
But and basically the idea was if it released tyramine, the tyramine would compete with the REMA to knock it off the enzyme so that you wouldn't have any MAO inhibition anymore, and it would be self-regulating. And I suppose that does work to a certain extent. But, I just think my colleagues, I haven't used it that much. I've had some patients come to me on it. It's just not worth the effort.
Got it. Okay, if we are concerned about side effects of MAOIs, Tom, what are some things we can do? Are there either strategies with how and when we dose the medicine or with antidotes or other treatments?
Again, I think the first two we hinted at. One is everybody gets a diet card, and you get them to say, I will follow it. I have some patients get a medical alert bracelet. You get hit by a bus, you're unconscious, you're in the ER, you don't want Demerol. So maybe there's some safety in something like that, or carrying your card in your wallet. So I think, there's just basic dietary education, which helps. And then using the one pharmacy, one computer. I know a lot of docs get nervous because it's a risky med. I think it's great to hand out a patient education pamphlet. You can find these online, and I don't make people sign it, but I told you this verbally, and I really want you to read it through. And then I sleep better, I think, because I've really gone through all these things. So I do think, those two things are important. It's tough. I've had some people get orthostatic and the drug's working, and then, we try to increase salt and fluids, carefully. Certainly if the patient's medically compromised, get help from an internal medicine friend. But I think salt and fluids, I've had to use Florinef, so fludrocortisone, way back in the day for a patient trying to bolster pressure. But yeah, sometimes the pressures bottom out and there's nothing you can do about it. But I've had patients where I've had to do that. If you create insomnia, you got to give, hypnotic sleeping pills. That happens. So it's kind of some of the same strategies we use with other antidepressants that create these same side effects.
Yeah, guys, my bias is that nobody's adequately hydrated, so I preach the gospel of hydration, to be honest, as far as the orthostatic hypotension. Steve, let me throw a curveball at you. Somebody's got somnolence. I've tried to deal with it by my dosing. Could I add a stimulant?
Absolutely. You need to get some experience with that. The most common, I think, unique combination for efficacy boost of an MAO inhibitor would be a stimulant. And this would also actually be for tolerability as well. So, yes, you can use either methylphenidate or D-amphetamine. I just haven't used Adderall myself, but I tend to use Dexedrine or even lisdexamphetamine.
I was going to say lisdexamphetamine might be nice, get a smooth all-day effect.
But start low, go slow, watch the blood pressure, make sure the patient, in addition to that diet card, has a blood pressure cuff at home.
Yeah.
Yeah, and I think the blood pressure we teach, it's additive, right? You're adding norepi to norepi. We're not talking crisis. I've not seen a patient go to 200 over 100, but they creep up because you're adding more norepinephrine, and that's what I'll usually see, but I don't see any.
Yeah, remember, there's an old-fashioned drug, I think it was called Parnate, I remember, and it was for Utenil. No, it's called Utenil. Utenil was actually an MAO inhibitor approved. I think it even still is approved, but maybe they don't have any meds around for hypertension.
Oh, you're kidding.
It lowers blood pressure. So the real problem is not hypertensive crises, although that's what everybody's saying because you want to avoid them, of course. The real problem with MAO inhibitors is they lower blood pressure.
Huh. Interesting.
Right. And I do think, if you remember, everybody's taught in medical school that these drugs raise blood pressure. Rarely, and with a diet problem, right? But the number one side effect, it's on every resident in-service exams, they statistically lower pressure, right? Yeah.
Yeah, it's actually
day to day, blood pressure goes down. Yeah.
Yeah. Okay. Now, we alluded to this earlier, but are there certain patient populations or conditions, diagnoses, or comorbidities where I should really be moving MAOIs up in my algorithm?
How about putting it in the algorithm?
Good point.
Look,
Yeah,
there's a million unique prescribers of SSRIs or SNRIs. I always tell people, do you know how many SSRIs are prescribed? 1. Actually, no, 7 per second, per minute, per hour, 24/7. So, it's millions and millions of them. And there's only about 1,000 unique MAOI prescribers in America out of a million. That's not even 1%. So if you want to be in the top 1%, this is how to get there. And so, the reality is that put it on the list. Okay, then the question is, how are you going to do it? Well, if you want to start with people that are really at the end of the line, that's one place to put it. Because, the other thing is, what are you going to do? Nothing. ECT or even ECT non-responders, that's where you could start it. Mm-hmm. But I actually think that, once you have, realistically, people are going to go through 1 or 2 first-line agents. They're going to go through maybe augmenting with an antidepressant, then augmenting with an atypical. It's just too easy. There's too much, I suppose, marketing out there about that. And it works pretty well. But then when that doesn't work, I think you need to slot this in at that point. In fact, I would give it before ECT.
Okay. Tom, how do you think about it?
Yeah, no, I agree. A provocative question would be, and don't get me wrong, the atypical antipsychotics are FDA approved, they work well. But I ask myself and my patients sometimes, let's say a 7 to 10% risk at TD, and you may be on this drug several years or longer, depending on your depression, and MAOI might be safer, right? If you follow diet and drug interact. And so, yeah, I think we have to challenge ourselves to think that the atypicals are perfectly safe and, and that kind of thing. So, yeah, I think it's a risk-benefit analysis. I think once patients are past 2 years of being depressed, the ECT rates drop off, right? So, again, can we move it up in the algorithm? Absolutely makes sense. I remember being at a lecture somewhere when I was in my formative years. Jay Amsterdam, I think, made this, your 4th antidepressant probably should be an MAOI. I don't care what 3 you try first, but at some point you should be doing an MAOI or ECT. If it's 2-3 months per drug trial, right? You better look at MAOIs earlier. And So again, I kind of grew up with that in my head. So I don't like saving it for the 8th, 9th treatment 4 years later. But yeah, I think that to me, I like the anxious distress patient, to answer your question. I kind of like my more vegetative, tired patients. I kind of do like the patch and maybe tranylcypromine a little bit. But part of the real issue is just convincing patients they're safe and we can use them safely, because a lot of my patients will decline them. That's the hard part.
Tom, thanks for those tips. I think I certainly agree with you. I was certainly taught, and I guess this gets back to the dopamine story, that for those with lethargic anhedonic, and I know, Steve, we've been talking a lot about anhedonia, and Tom, you have too. And, it seems to me that if you're just increasing serotonin, you're not touching anhedonia that much, but dopamine's really the player you want to bring in. So this is another way of addressing anhedonia.
Yes, and motivation, and then, of course, sometimes this sharpens cognition.
Yeah, I would think so.
So absolutely an excellent point.
Okay. All right. Now, if clinicians want to learn more about this, I certainly hope we have stimulated some interest here. Steve, would there be some information in the prescriber's guide even?
Well, of course, everybody needs to have Stahl's prescriber's guide. I'm teasing, but yeah. And actually, NEI also has it online for members and so forth. There's lots of ways to skin that cat. But the other thing is there is a publication that came out in Psychiatric Annals recently. It's called The Prescriber's Guide to Classic MAO Inhibitors for Treatment-Resistant Depression. It's in CNS Spectrums, and it was published, I think, just a few months ago. It has like 40 co-authors on it.
You're on there somewhere.
And so, the reality is that most of the experts signed off on this. So that's an easy way to get started. And then the other thing I would really recommend is that I have a hand-holding opportunity for the listeners out there. Okay. And that is all these crazy people who signed off on this prescriber's guide. And I think they have to be old in order to actually qualify. Are available at Roundtable at maoexperts.topicbox.com. Let me say it again. Roundtable at maoexperts.topicbox.com. And if you say, I have a patient I want to, and they're on doo-doo-doo, and I need to have DDD, what should I do? Or I've tried an MAO and I'm scared, and what should I do next? You can get some hand-holding, basically mentoring, I really mean. We are that dedicated. This started actually from a colleague that's well-known in this field, but maybe not in the States, Ken Gilman. He's an Australian that has for years been an advocate of MAO inhibitors. And so these are worldwide experts that have probably the last vestige of experience with this, and we're all about to die off. So please, people listening on here, please get that. So what happened is I was asked by the APA 2 years ago to give a workshop on MAO inhibitors because they felt it was a dying art. And I did that, and there was a great deal of interest, and then kind of a little bit of a spike in use. And we also exhibited and organized this roundtable. So somebody will chime in if you want to do that. And I don't know, we can actually put it in the podcast at the end again, roundtable at maoixperts.topicbox.com. And please use it freely. And also look at the prescriber's guide for MAO inhibitors in CNS spectrums. And then, of course, I do have those two drugs. In fact, we freely will send out just the PDFs of those two drugs if you email us. I think that we're very strong proponents of trying to do everything possible to reduce the barriers to using these agents.
Could not agree more.
And
Tom, are there any other pearls or tips that you would give clinicians who want to learn more or get more comfortable?
Yeah, the two things. I think somewhere back in the NEI video archives, I actually remember co-teaching most of this content with Dr. Stahl.
Yes, I remember that lecture.
So that's got to exist somewhere, and it really covers the basics like we talked about today. And remember, covering the myths, the things that we're told you can't do. So that's got to exist somewhere. We'll have to dig that up. But I think find a mentor, that can walk you through this. So find somebody who's maybe a little bit older than me, my age or a little bit older, that grew up with these. And
don't look at me when you're saying that, Tom.
Have a 15-minute conversation about what did you learn for the 30 years where these were kind of some of the only drugs we had to use. Yeah. And then it's very calming when people have used these a few hundred times and they didn't hurt anybody. But you can be textbook smart. You can be kind of real world smart by talking to somebody who's lived it, right? And then you feel a lot more comfortable.
Well, guys, I have a story that should hopefully help people to feel a little more comfortable. When I was in my training, I had a wonderful guy who was I did internal medicine residency and psychiatry. And internal medicine, my chief resident in internal medicine was on an MAO inhibitor. And he would talk very openly about it and how it changed his life. And if this guy in training, wanting to be very careful, would take an MAO inhibitor, then maybe we shouldn't be so afraid. If it's good enough for him, it's good enough for us.
Yeah, and I got to tell you, every now and then, a couple months ago, my physician's assistant came to me and said, I had a gentleman, he specifically came here requesting an MAOI.
Wow.
Did his own research and would really like to try maybe his third antidepressant, maybe a year. And again, it was an interesting question. Should we go this aggressively this soon?
Yeah.
But every now and then you get a patient that's read up on some of these things and they come in and request one. Yeah.
Tom, you mentioned using a specific pharmacy. I can imagine these drugs are not widely available at pharmacies. They probably have to order them. So maybe it does make sense to use one that's going to get it in stock and be familiar with these things. Is that right?
No, it's correct. You'll probably have to wait at least a few days for them to get it in. Yeah.
The other thing about this is that pharmacists aren't trained any better than we are.
No,
and
that's
so that you get all sorts of calls when you have this from of panicked. People have misperceptions about what you're prescribing, and the other thing, the most famous one is if, God forbid, your patient needs surgery, the anesthesiologist have an anaphylactic reaction to patients on MA inhibitors. They say you have to stop them or we won't operate. If you get hit by a bus, you can actually have inhalation anesthesia, and you can have IV anesthesia. Again, they need to know how to do this as well. So having some idea of how to anticipate, because the other thing is if you're not confident, then you'll probably stop the drug.
Yeah.
And so I can tell you that these things will happen, but go online. You'll get a response in 24 hours, chances are. And again, Tom said we can dig that up, but Megan Grady and I from NEI put together myths about MAO inhibitors a couple years ago. I think it's also in CNS spectrums. Which has to do, what do you do if you need anesthesia? What do you have to do if you go to the dentist? The dentists don't like this, but the only thing they shouldn't do is inject epinephrine in you with your lidocaine, because it could be absorbed and it's going to be localized, but it could raise your blood pressure a little bit. So, dentistry, surgery, and, the anesthesia are all things that happen to real people if you're going to use them long term. And managing that it doesn't take rocket science, but it does take some confidence. And those are all covered in some of the publications. And I guess if there's interesting demand on this, we could have a follow-up pod with some very specific things to do about answering all those questions, because there's not enough time to cover the specifics of them, but we're happy to do that.
Yeah. Yeah, you're right, Steve. I mean, if you think about it, there's so many medications that have a warning about not using it with MAOIs and having to be off them for 2 weeks and this kind of thing. So people, I think, generalize and get really afraid of these drugs when you really don't always have to be. Speaking of that now, Tom, let's talk a little bit, just real nuts and bolts practical. If I want to use an MAOI, odds are somebody's on an SSRI or an SNRI. How do I make the switch?
Yeah, so the rule I use, I like 4 to 5 times the half-life. And so everybody doesn't need 2 weeks, 4 weeks, 8 weeks. I get out an app, I look up the half-life, and to be safe, I like 5 times the half-life. So some of our drugs are short half-life. People could start 5 days later.
Yeah.
You don't always need a protracted washout, but you got to do the math. You got to look these things up. So that's the approach I use. And then, certainly if you're coming off an MAOI, you're going to want to wait 2 weeks, right?
That's a really good point, Tom. You got to learn how to wash in and wash out too. That's part of the skill training here. And also, what do you bridge with? Those are very important things, and they have to do with drug interactions and understanding half-lives.
Steve, there's something you can bridge. How would you bridge?
Well, you can bridge with stimulants. You can bridge with benzodiazepines. You can bridge with trazodone. You can bridge with mirtazapine. There are. Depends on the situation.
Not a reuptake inhibitor. A lot of people don't realize that.
Yeah, I think you're right. I think you can at least control sleep, agitation, benzos, BCRAs, DORAs.
Atypicals, except for lumateperone and ziprasidone.
Yeah. And so I do think, and that's one thing that scares patients too. I'm going to be on nothing, right? And then I think that psychologically gets them worse at times too. So I do think you're right. It's kind of some bridging ideas make sense.
Yeah, absolutely. But the point is that probably they're going to be on something else, and you're definitely going to want to do this. I guess the two traditional antidepressants you want to really worry about are going to be fluoxetine, which has a super long half-life, a couple of days, and vortioxetine's half-life is in the 60-something hour range. So those two may be a little longer, but for most of them, 2 weeks certainly is more than enough. And then there's the question of, okay, if I want to switch off the MAOI to something else, do I have to wait a long time there on the back end?
Yeah, I mean, I like 2 weeks is what I like for the most part. Yeah.
The half-life of mitochondria is 10 days. So you will replete a new set of mitochondria every 10 days. And if you replete, basically 1 or 2 sets of mitochondria, which is for, 14 days, you'll have enough mitochondria making, because if MAO inhibitors have washed out of the blood and a new mitochondria is there, so MAO is in the outer membrane and it works. It's not inhibited. Yep. So that's where I get it from. These are all rational reasons for what we're doing.
And I guess the MAOs we're talking about are all relatively shorter acting. They're not lasting a long time.
Well, they are suicide inhibitors, which is a bad term, I suppose. What that means is it kills the enzyme. So that they're irreversible inhibitors. They actually, you may remember that MAO has flavin in it. And so these covalently bind to flavin and kill it. So it doesn't allow the enzyme to work. And it won't start working again until you make another protein. And if there's no enzyme inhibitor present, it won't be present. But actually, if you're bathing the brain with MAO inhibitors continuously, every time you make a new mitochondria, it gets inhibited immediately.
So if you stop the MAOIs, though, their half-life is short enough that, they're going to be gone in a day or so, I guess, and then you're going to be all right. Yeah, I guess
it's just that it'll cling into the old mitochondria, and so it's washed out of the plasma, but it's sticking to the old mitochondria.
Got it. All right, well, guys, we're running up against time here. What can we finally say? I mean, I really want to get people to rediscover these medicines. They're so darn effective. What can we say, just as final last words here, to really put a cap on this? Tom, what would you tell our colleagues here who, we need to get them over the hump of whatever fear or concern they might have?
I think I'm a realist, too. I think people are still going to be scared and save these for the 8th, 9th, or 10th medicine in. And again, maybe some of these niche populations move them to the 4th, 5th, or 6th medicine. That's pushing the envelope, I think, for the average, usual clinician. My word of advice, even if you're 12 meds in, they're 5 years depressed, it's still worth a try, right? It's a different mechanism, and it's worth trying. And then you're still going to get used to using the meds. So even if you want to save it for before ECT 5 years later, it still makes sense to try it and get comfortable with it. Yeah. And it may not work as good because you didn't use it, but you're going to get comfortable. And then you start moving your envelope earlier in treatment. That's, I guess, what I would leave with.
Yeah, I think realistically, we're not going to get all of our colleagues to use these. But Steve, if you want to be somebody special, if you want to be seen as an expert, if you want to be offer something different, would this be a good idea?
Yeah, I think that basically the so-called psychopharmacologists in a community should know how to use those three agents you said, clozapine, MAO inhibitors, and lithium. And, if you can do that, you can... and maybe everybody doesn't want to do that, but I hope that each community has somebody to whom you can refer that does know how to do that.
Yeah. Yeah, not everybody has a Tom Schwartz, unfortunately, in there to help them.
But that's another strategy, right? Get a consultation and have somebody, walk you and your patient through it. It's another idea, right? Find that person in the community that'll help you learn it. Yeah.
Yeah. Sounds great. Well, listen, guys, thank you so much. This has been fun. Rediscovering some things that I'd learned quite a while ago in my residency about these effective medicines. Really want to thank you both for your time. Tom, thank you.
Thank you.
And Steve.
Thank you.
All right. Thanks, everybody, for listening. Hope this was helpful. And again, really consider this as another option to offer something different to your patients. And I hope you enjoyed this podcast. For other educational products and opportunities, please go to our website, NEIglobal.com. Thanks so much, and good luck with your patients.
Thank you for joining us for another episode of the NEI Podcast. Please let us know what you'd like to hear more about by leaving a review. Don't miss another episode. Subscribe today. For more information about NEI and our premier educational content, please visit NEIglobal.com.